August 21st is our chairman or our chief Dr. Sundaramurthy's birthday. Every year it would have been a regular celebration at hospitals in the form of puja and birthday celebration. Post demise, we have declared this day as Founders Day at our Lotus Hospital. And last 2-3 years we had webinars at our hospital, and from this year on request of our MD, we decided to make it as a program at Coimbatore level. So we all would like to again welcome you all. I request our MD, Sangeeta Sundaramurthy, to say a few words.
Good evening to everyone. Today is our Lotus Eye Hospital and Institute Founders Day 2024. It is a birthday of our founder, Dr. S.K. Sundaramurthy. Like Dr. Anand said, every year we celebrate our Founders Day in remembrance of him in some special way. This year we wanted to celebrate this day by organizing a symposium. Dr. S.K. Sundaramurthy started his practice in a small clinic in RS-Puram in 1992. He always had a very clear vision about his career and calling in as a doctor. This led to the creation of the brand Lotus in 1997, and there began the dream journey. As we stand today, the brand Lotus has grown leaps and bounds into 9 centers across Tamil Nadu and Kerala. The pivotal reason for our success has always been the strict adherence to the guiding values and principles of Dr. S.K. Sundaramurthy. He ensured not only continued eye services to the public, but also imparted his knowledge and trained many, many doctors who today are the leading ophthalmologists in the country. As part of our Founders Day, I would like to welcome all the eminent doctors and other personalities to this event. Thank you for making the time to grace us with your presence. I take this opportunity to thank Dr. Anand for putting in a lot of hard work to organize the symposium, and all our doctors. Thank you so much.
We are always under the guidance of Dr. Ramalingam, who is a noted nephrologist of this region and director of Coimbatore Kidney Center, and is working as CEO of our Lotus Group. I would request Ramalingam sir to say a few words.
My dear Managing Director of my group of hospitals, Dr. Anand, my friends, Sundaramurthy, Dr. Sundaramurthy, we called him as Sundaram very affectionately, was my roommate, classmate, and very, very close friend. And because of the fact that he had discontinued for some time during his school days and then rejoined the school and came on to do the medicine. He was senior to me in age, and he was always sort of a person who looked after me and many of my friends with a very sort of a careful and very affectionate attitude, advising us about a lot of things. His loss is a great loss to me, and I'm happy that I'm associated with the institution he created. And today, as you all have come here to discuss some new advances in the field of ophthalmology, I am reminded of his telling me that he was organizing a conference on a ship long back. I never thought that it will be successful, but contrary to my belief, it was a great success. And I'm very happy that you are all here. And it's not necessary for me to tell you this. I am very sure you all know this, and you don't have to be reminded. But due to the fact that many of us are very busy nowadays and don't have time to remember a few things, it becomes useful for me to tell you. The text, quickly I will tell you this. Harrison's textbook of internal medicine, you all must have heard or read sometime or other that. The first edition, the Tim Harrison says, as the qualities of a good doctor. One, scientific knowledge. Second, technical skill. And third one is human understanding. And these he enumerates as the good qualities a doctor must have. The scientific knowledge goes on changing. Long back, nobody thought that something injected into the eye will damage the kidneys. But now it is proven that even some injections into the eye can cause damage to the kidneys. So like that, long back, nobody thought that an immunological event will damage the retina. But now you know that the complement can damage the retina. Like that, there are a lot of advances, and I am sure this meeting will be a useful one for people who are too busy to read and not able to keep up with the advances. I wish all of you a good meeting, and thank you for coming. Thank you very much.
Thank you, sir. Thank you for your words. And I've laid out this program in such a way that all these topics were our chief's favorite topics. So, of practical importance, I've spoken to all the experts of our city, and let's listen to them. Dr. Vidya, please.
A warm welcome to one and all. Let's begin the day's session today. And for the first session is different PCIOLs for different needs. How do I choose them? I request Dr. Rita Singh as a moderator and Dr. Satyan P. as the panelist.
Good evening all. We are amidst an array of assorted IOLs with latest technologies like multifocal, EDOF, and trifocals. We need to cater our patients with our best care and our scientific knowledge. So how do we customize our lenses to serve our patient better? Let us hear it from our premium phaco-refractive surgeon. I now call upon Dr. Anand to share his vast knowledge and experience.
Again, good evening to all presbyopic correcting IOL surgeons who have gathered here. So, my topic is different presbyopic correcting IOLs for different patient needs and how to choose. So, this presentation was actually made by me for a closed group meeting 2 weeks back for half an hour. Now I have condensed it. I will be showing in a very short while. No financial disclosure confined to this talk today. This is just because of Founders Day Symposium. We all know the three important presbyopic IOLs: multifocals, trifocals, and EDOF. Multifocal is actually a misnomer. This name was given even the before of trifocal was discovered. This should be called as bifocal. Many of the practicing surgeons here, we do practice still multifocal lenses. We offer it to the patients who do not demand intermediate vision. People from rural background and people, small shopkeep owners, and who are not into much smartphones, still it is doing good. The trifocals functionality has improved. It has got 3 foci, and EDOF lenses, we know there's a large range of foci. Trifocal lens do provide very good vision at all the 3 points. There is loss of some vision at some ranges. Dysphotopsia has been literally very minimal. The IOL manufacturers have improved the technology in such a way that the amount of energy lost when the light is passing through these diffractive rings is less than 15%. Because of which the amount of contrast loss which is happening is not so significant, and the amount of dysphotopsia which is happening because of diffractive rings is very, very minimal. We are happy with this sort of lenses. Each and every IOL manufacturer calls this in a different name. Biotech calls this as Bliss, Care Group calls this as DET, J&J calls it convolution, Alcon calls it Enlighten, and Zeiss calls it as smooth microphase optic design. EDOF are on the rise. So EDOF lenses, their vision should be superior when compared to monofocals, and the intermediate should be very, very good. The depth of focus should be good. We classify them, as well know, into pure and hybrid. For any EDOF to work, there are three principles. Either there is a modulation of asphericity, either it works on pinhole effect, or there is a achromatization effect. So among EDOF, the pure EDOFs, they give with bilateral implantations excellent functional intermediate vision, whereas the hybrid EDOFs almost give functional near vision, and they are comparatively having less photic phenomenon when compared to any other trifocal lenses. This is regarding the IOLs, what we have present today. What are the patient needs? Whenever patient comes to us for a premium cataract surgery, we need to listen to him. Let us listen to his complaints, what are his desires about his spectacle independence, and what are the expectations. And we need to understand what knowledge he has got about it, and finally, his affordability. We need to pay attention what is his occupation. Is his occupation needs a very good contrast vision or not? If we fail in this part, we can never become a smart surgeon. This is where we have to be very careful. There are some concerns not to take up presbyoptic correctors. This varies from hospital to hospital, region to region, place to place. Mainly, it can be a cost issue. It could be concern about their contrast, or it could be concern about their photic phenomenon. And majority of the times, information is available to each and every person. They might be fearful about this side effects. Once we understand the patient needs, once we know about the trifocal events, to make this PCIOL successful, there are some pre-op assessment, intra-op assessment, which I'll be discussing it right now. How to choose them. Whenever it comes to choosing, I divide this things into three things: psychological, biological, and occupational. Psychological means these smart lenses are not only for smart people. Even surgeons should be smart enough to identify who are these patients who are really motivated for these sort of lenses. Are they realistic about these expectations from these lenses? In my practice, almost 60 to 65%, I feel the women population takes up the presbyoptic IOLs in a bigger way when compared to men, and they have much more tolerability when compared to men regarding the suboptimal quality of the vision. This is one chart which explains the relationship between the refractive error and the cataract while selecting PCIOLs. We should be very careful when we are selecting a patient with no cataract and refractive error. That means in a very early price group. A patient with a moderate myopia and early cataract can be ideal patient. Low to moderate hyperopias with cataract can be ideal patient. Extremes of hyperopia or myopia, again, biometry can be a challenge. Surgical issues are there. Right candidate, we need to pay attention to this thing. Majority of the times, the patients do talk to us, I have driving the trifocal disturb. But most of the times, in my experience, I feel that majority of premium patients, they do have drivers. Driving is not a main concern for them. We should not make them feel bad that driving itself will disturb. The technology is so improved. So we need to pay attention to their driving times. So highly motivated candidates are the ideal candidates. If you're literally taking time to convince about technology, they do not become the ideal candidates for PCIOLs, and presbyopes without refractive errors, say no to them. Next, coming on to choosing the right eye. So we need to pay attention to the tear film, slit lamp examination, pupil and angle kappa. Presbyopic age group, again, they are more prone to develop the modern lifestyle, the dry eye, this thing. Preoperative dry eye, if it is neglected, that can become a cause of concern or a cause of disadvantage post-IOL surgery, even in spite of patient being emetropia. Have screening tool, topographies, non-invasive tubers can give us a very good clue to diagnose dry eye. If at all, if you feel dry eye, it has to be treatable prior taking up to the surgery. Slit lamp examination, rule out dystrophies, rule out macular issues. So trifocals doesn't work here. Contrast is an issue. So EDOF lenses can be a good choice even in presence of wet macular conditions and in progressive glaucomic dystrophies, but not trifocal because contrast can be affected. Pupil has to be plays a very important role. Angle kappa more than 0.5, we have so many methods to measure it. Each and every institution has it. Be careful if you are putting trifocals in a patient of exophoria, exotropia, and a patient suffering from convergence insufficiencies. Adolphs can be still tried if the angle kappa is more, but no to trifocals. Biometry, we have almost shifted from immersion to swept source OCT today. We are able to calculate the corneal astigmatisms. Do not forget the postal corneal astigmatism, because presbyopic IOLs do not forgive if you don't respect the astigmatism. If it is less than 1, I personally prefer to do LRIs with the use of my femto. If it is more than 1, I prefer to go with the toric IOLs. And universal Barrett 2 works out very well for extremes of biometry. Coming on to the IOL, there are so many companies which come out with the multiple technologies. We need to understand the optics, apodized, non-apodized, what's the amount of energy distribution, know from the industry, know from the experts, and what is the satisfaction rate with this, and the ease of implant, their tensile strength, and choose your IOLs. And finally, at last, make sure that you'll be making 5 to 5.5 mm Rexis, a good hydro, and make sure that you put IOL in the bag. If you have access to flex, sorry, my videos are not playing. So, finally, if you have access to flex, nothing like that, all the time you get a central round regular Rexis, which is the must category for presbyopic IOLs. And finally, to conclude, you go with enhanced depth of focal lenses if patient wants very good distant vision, good intermediate vision, but try to use near vision glasses but no dysphotopsias. Extended depth of focus lenses, bilateral implantation, excellent functional near vision but no driving issues, but has to depend on near vision glasses. Trifocals, good vision at all the points, but can be associated with reduced contrast and dysphotopsias. Thank you.
Thank you, Anand.
Thank you, Anand, and it's a wonderful talk. Of course, we all have kind of confusions and what kind of a lens to choose. I think it is going to be a one-day symposium as such, but I think you have just given a very brief of how things can be done. Having said that, just curious to know that is that the trend has shifted from just the monofocals to the EDOF now in all our regular practices? What about your practice?
That's true, sir. So, I actually forgot to add up that slide. I always tell presbyopia is affecting mid-40s, but one more cause of epidemic presbyopia is implanting monofocal IOLs. I think we should start implanting less of monofocals and go with more of EDOF lenses or trifocal lenses. And even the trend has increased in our practice at least.
Is it for economics or for the patient betterment?
I think the increase in number tells us that patients are also happy, we are also happy.
We have our, Dr. Chitra Madam is also here. Yes, please. You can also.
It was nice presentation, Anand. But recently I have added one point while choosing lens is, if you can't explant, don't use that lens. So because nowadays explantation also increasing, and recently I was struggling by explantation with the IOL. I don't want to tell, but especially when the refractive index is very low, there will be little bit thicker lens. So we can choose with the refractive index which is like 1.5 to 1 above, which is very easy to expand. So this is just one point which I have added.
Madam, you're also doing a lot of EDOFs. You want to just give some comment?
I think as Anand had said, patient selection is the criteria. And if we can understand the need of the patient, we have all the range of lenses. And of course, we have to consider even smallest astigmatism, because only then these premium IOLs are well received. And I think diverting gradually into premium surgery, if the patient can afford, is the way to go to differentiate a successful practice from a not so successful practice.
That's a good comment.
Thank you for that wonderful talk, Dr. Anand. And may I now call upon Dr. Rajkumar Chaurasia as the moderator and Dr. Prabhu Shankar as the panelist for the next topic on tips and tricks for soft cataract surgery. I request Dr. Ganesh V. Raman to kindly give his talk.
Thank you. At the outset, I'd like to thank Lotus Eye Hospital family for the invitation here. So I'll be speaking to you on reverse the one. Soft cataracts, tips and tricks. A simple presentation, more so for, since we have some of the postgraduates here. On. We in Coimbatore, we've been 20 years back, and I remember what a great surgeon and teacher Sundaramurthy sir was. And we used to meet, once in a while. But I remember his classes in TNOA. That's where he used to teach very nicely. A lot of classes I attended, a lot of sessions I attended in TNOA. So coming to the soft cataract part of it, so most of the soft cataract patients are usually young patients, and they invariably have association with posterior polar or posterior subcapsular cataract. And sometimes, since I practice glaucoma, I find that some of the softest cataracts come in glaucoma as well. And of course, you have another group who have undergone retina surgery and they need the cataract removal for the procedures. So biometry is very important in these patients, mainly because they are, you got to get your IOL power calculation spot on. And many of these young patients work in the digital work environment. They have very high expectations. And usually, as we heard, premium IOLs, they opt for premium IOLs. And you may need to plan the fellow eye surgery sooner than later. So that's another thing which you have to be careful about them. And surgical challenges are numerous. So soft cataract does not usually lend itself to standard steps of nuclear disassembly. So if you do a brisk hydrodissection, as the surgeon is doing here, you can have the nucleus prolapse into the antechamber, and rotating that nucleus can be quite difficult. You also have a cheese wiring effect, especially when you're cracking and chopping the nucleus. Lens matter is quite sticky, difficult in separating from the the capsular bag, and traditional steps like trenching, sculpting, and chopping are really very risky. And you have to anticipate the soft cataract, how it will behave. And if you see a young patient, and if you have a posterior polar, for example, this was quite interesting as I was washing, and I found a pool of fluid behind the PC. So when it stopped irrigating, I found that the pool of fluid coming into the antechamber. So there was a small breach there. So unless you anticipate that, you will miss that. So PPC, even if there's no breach, there could be a small breach in the posterior capsule which may not extend. And machine parameters also, you have to be careful. You have to use lower settings, power, aspiration, flow rate, vacuum, everything has to be reduced. And the epinuclear mode is quite difficult because some of them will have a thick epinuclear sheet. Phaco energy is very reduced. Vacuum is 150 to 200 millimeters of mercury. Aspiration flow rate is less. And all this is due to reduce the chance of surge and posterior capsular rupture. And constantly you have to do a intraoperative titration. Anesthesia, we usually do we can practice a topical anesthesia, but since we have the combination of phenylephrine, tropicamide, and lignocaine available now, so topical anesthesia becomes quite easy. And of course, all these depends on the patient's ability to cooperate, surgeon's experience, ocular comorbid conditions, status of the cornea, small pupil, posterior polar component, and previous ocular surgery. Capsular rhexis, needless to say, is challenging because of the elastic nature. So it's very useful to use trypan blue, and always use a high molecular weight viscoelastic device. And tearing of the rhexis, cogwheel, or the clover leaf pattern can also occur once you're doing the capsular rhexis. So the idea is to get a 5 to 5.5 millimeter rhexis, as much as possible, so you get a good wraparound effect of the rhexis margin over the IOL optic, and also permits the safe removal of the cortex. And the hydroprolapse, as you saw previously, that doesn't prolapse the lens into the crystalline lens into the anterior chamber. And in case of a PC rupture or some inadvertent eventuality, you can always use the rim to place the capture the optic inside the bag with the haptics in the sulcus. Hydro procedures are again important. So cortical cleaving hydrodissection is something which you do. So how you do it is you insert the hydrocannula and lift up the anterior capsule and move the anterior capsule, move the cannula left and right, so that you create some space there. Okay. And once you did that, you will have a good hydrodissection. Otherwise, you can also practice hydrodelamination as shown here. So in situations where you have a compromised PC, like anticipating compromised PC, like posterior polar cataract or post-VR surgery, post-traumatic condition, and also avoid nuclear, you can have the rotational nuclear disassembly can be a little easy. Yeah, you have it here. So this is how you can practice cortical cleaving hydrodissection. So lift up the cannula and then you give a short burst of hydrofluid. Nucleus management, you have the endoscapular technique and the chip and flip method. So in the endocapsular technique, you have the delaminated nucleus, as you can see here, and then you create a crater right in the center. And disembowel the center area, so you have the peripheral cortex and epinuclear matter, which then, if you can flip it into the antechamber using a hydro or using visco devices, you could do that. You must remember there's a posterior plate which gets left, which may have to be removed in total later on. So the surgeon is okay, since I don't think I can control this, can we have the presenter slide off? Yeah, here. You see there's no nuclear rotation. It's very, very difficult. So what the surgeon does is he flips everything into the center and tries to aspirate it. So this is the chip and flip technique. And if it's prolonging, you could use viscoelastic device to bring all the material into the center and then aspirate it piecemeal. So these are some of the difficulties in doing a soft cataract. And you can see how difficult it is to rotate because of the cheese wiring effect of the nature of the cataract. The other technique is, once you have a posterior pole, the one pole of the nucleus out, you could use the phaco probe to aspirate whatever remaining is there. So epinucleus management is, again, as you have seen, it's quite difficult. It is carouseled out of the bag and removed in toto. So you use zero power and low vacuum and short burst of phaco power. And if the plate is left, you viscoprolapse it and then remove it from the chamber. Cortex removal is again quite tricky. Because of the young patient's nature, you have a very high chances of PCO formation, which is quite aggressive. So you could use bimanual IA or a J cannula like this, which has a bent tip. And the posterior plate can also be removed by using a polishing device. And once you are done, you place the intraocular lens. So in summary, it's one of the most challenging procedures in cataract surgery because of the young age of the patients. Nuclear cataract is minimal, so you cannot phacoemulsify or use your conventional procedures, and because of the high expectation, you have to give sometimes supra-optimal results. Thank you very much.
I think the most difficult ones are the soft cataracts. So only thing is, if it forms a crater or a bowl there, that's time we'll have too much of problem. And one thing is, the longer you're staying inside the eye for a soft cataract, the chance of PCR really is very high. So somehow you have to, as you say, either you have to flip it up, or I think the best technique now is put visco, remove one, lift one pole up and complete your phaco. That's the best technique.
Actually, I want to tell something, not ask. Can I ask, what was the age of the patient who first video? It was. Actually, what I have seen, if the age is 47, before that you can aspirate. After 47, you can't aspirate. So the second one, age must be 40 plus something. And first one must be 50 around. Like now, I can categorize on the basis of that just by seeing the age. So what I have seen, after 47, sometime plus minus 2, 3, you can't aspirate. You have to use power. And in soft cataract, not only young patient, like soft, we are telling when there is we can't chop. So when there is no nucleus, that is a difficult case. So whether it is 85-year-old cortical cataract or 3-month-old baby. So 3-month-old we can aspirate, nothing to do. But when we are operating an 85-year-old person, and especially diabetic and non-dilated, that is the most difficult things. After finishing that, like I have started calling myself finisher. Somehow we are finishing. It is not like that which method you apply. You finish it. You finish it without it. So it is like a finisher. And that is the problem with the phaco. Like we have only power and we have aspiration. So power can't be used and aspiration can't be done. Then what else? So combination of both we have to do, and just somehow we have to finish the case. Okay, sir. Thanks.
Thank you, Dr. Ganesh, for those wonderful videos. Now we move on to the next session. And here we have Dr. Satyan, sir, and he will be speaking on the management of IOP fluctuations after cataract surgery. I request Dr. Usha Raghunathan as moderator and Dr. Satyan N as panelist for this talk, please.
Thank you, madam. It is a wonderful evening. Welcome you all for this wonderful evening on Dr. Sundaramurthy sir's birthday. Happy birthday to you, sir. So we all miss him a lot. Definitely a visionary leader who has created many ophthalmologists. And my association started ever since 1992, ever since he started his Araspuram clinic. So he used to give a lot of advice for us how to, practice ophthalmology. As a management side also, he used to tell us how we can do things better. So with that few words, I would really like to sincerely thank Sundaramurthy sir for creating such a wonderful chain of hospitals. He has developed it as an organization. And there are a lot of things which is helping the public at large. And I sincerely thank Team Lotus. I wouldn't point out only Anand for this, but of course Anand has taken a lot of effort to do this. But I would like to sincerely thank the Team Lotus for taking up this wonderful event today. So he has given me a topic on managing the IOP fluctuations after cataract surgery. We are really happy with all the cataract surgeons, especially those who are learning surgeons, because you are our feeders. So we are really thankful to all of you. As a glaucoma surgeon, as many as you can give us, we are happy. And as the primary glaucomas are much more prevalent than the secondary glaucomas, we wish that you continue to give us more cases. But how you can reduce the number of cases to giving us. So I am Dr. Satyan. So it is usually when you really look at all your patients after you do the surgery, it is about 8 hours is the peak. So when we were doing the study earlier, like in 97, 98, this is one of my studies. When we did the trial, it was peak is at 8 hours post-surgery. And by 12 hours, it slowly comes down. By the next day morning, you see most of the cases will come down to close to normal values. But none of us see the patient at the end of 8 hours. We used to do our regular rounds
in the evening, but we never see the IOP. But if we have to see the rounds at Arvind, then we have to see about 500 patients post-op. It is not possible. So only about 1.3 to 10%. 10% is pretty high. I'm not sure why the manuscript shows about 10%, but some places I think it is 10%, but 1% itself is a little higher number. But everybody usually will come down. Maybe very few people may get into the problem. Sometimes there is an events which happens in clusters. So we had from one center we had about 7 patients who were kind of not under control with any kind of medications. So I'll just discuss that little later. So usually the increase in intraocular pressure after cataract surgery is very benign. It just goes off automatically. Those patients who have their optic discs very fragile kind of things, where the watershed zone is very weak, have a very high risk of having some damage. But those with the kind of prone for AON, or patients with diabetes, nocturnal hypotension, anemia, systemic hypertension, are at risk of possible further field loss than those without those problems. There are various risk factors. Eyes with glaucoma, of course, they are one of the most vulnerable patients. I'm sure that some of you, whoever has done the high myopes, the moment you do the stromal hydration, you can see that the pain comes to them, and then you can see these patients are the ones who will really have a higher IOPs post-operatively. Those with the poor pupillary dilatation who have a higher elevated IOPs at the, like 20s and 25, those kind of patients. Exfoliation syndrome, we all know that it is not necessarily those patients who have a pseudo-exfoliation need to be having a higher IOP to begin with, but these patients also do have a increase in the intraocular pressures, the post-cataract surgery. Those with the shallow anterior chambers, we are talking about the angle closure disease patients. And of course, you can see the thicker lenses, again, they will have an angle closure kind of disease. And what is the most common problem we come across is the OVDs, that is the viscoelastic devices. And the surgeon who really takes a lot of time, messes up the entire surgery. Those are the cases where we have to be really watchful. And very tight water-closed wounds, more so in a SSCS patient than those with the phaco wound. The retained lenticular debris, we'll just discuss that. Release of pigments, and when you do the surgery, there is a possible bleeding, and then you can see the postoperative hypema. And when you have a PC rupture, of course, all the complications of the surgery. And the patients who have postoperative inflammation, it may be for various reasons the patient may have the inflammation, and those who are on steroid usage. So I've almost given the entire spectrum of possible causes of the postoperative IOP spikes. But when this usually happens is postoperative day 1, the patients who have a pre-existing kind of a glaucoma, are those where you have left out the viscoelastics and some kind of inflammatory response. These patients may have the higher IOP spikes, and at the end of week 1, you may have again those with the steroid responders and the glaucoma patients, and also those who are having a higher amount of inflammation. At the end of 1 month, if you see, most of them will be settled down, but those with the steroids, higher amount of steroids, may have a higher chance of having the IOP spikes at the end of even 1 month. And also, of course, less common is the retained nuclear materials. So as I mentioned, those with the pre-existing glaucoma patients have the greatest risk of developing postoperative IOP spikes. So you have to plan, whenever you are planning for a glaucoma patient, the cataract surgery, you must know that the postoperative spikes are going to be there. So you must be mentally preparing how you want to tackle. When you really look at the OVDs, it is not only high molecular weight, it is not that alone. Even the low molecular weight, it's probably because even the reactions which can happen, these patients, they do develop kind of a trabeculitis, postoperative sudden shutdown of the trabecular meshwork which happens. So that is where you have this clusters. You may not have any complications. You need not have a PCR or there's no need to have inflammation. You could have just washed out even the OVDs, but they develop some kind of a toxic response where they have the toxic tuberculosis. So these patients will never respond to any of the management. Then we end up doing the traps in these patients. We have done quite a few clusters from elsewhere referred. We have done that. The steroid response, again, it is one of the very commonest things. If you are not noticing, you have to just notice the dull corneas post-op when the patient comes in. Then you just check the IOPs. It is not necessarily that everybody has to have a kind of a good amount of corneal edema. Even a very dull-looking corneas, we must just look at the IOPs and make sure that if the IOPs are higher, stop the steroids. You have to understand whether it is a steroid responder. Stop the steroids, switch over them to NSAIDs, and of course you have to start them on the anti-glaucoma medications as well. The retained lens material, again it is, you can see that there is a low-grade inflammation always happens there, and you can see the localized area of corneal edema near the nuclear fragments. Whether the nuclear fragment is small or big, if it is just a cortex, probably it will just get absorbed, but if it is a nuclear fragment, it is better we kind of remove it so that the entire problem settles down. Otherwise, it is going to be keep on having the inflammatory response and the corneal problems. The inflammation, again, it is not only because of the OVD, it could be just because of the patient's nature itself or the manipulations which you are doing during the surgery. All these things can cause quite a severe inflammation. It is not only the inflammation, maybe patient having an infection also. Along with the inflammation, all these things will cause active tuberculosis and acute shutdown of the trabecular meshwork functioning. So these patients may end up going in for a trabeculectomy. PC rupture, it is quite common in earlier days, like when you are beginning as a surgeon, but usually the later stages the complications are much lesser. But whenever you come across with a PCR, just you have to make sure that we have to thoroughly wash the OVD and get some seniors help to make sure that everything settles down. So same, once you have the higher IOP, you have to just make sure. But when you are putting other type of IOLs, especially like iris claw lens, or like when you are going in for a SF IOLs, then you must make sure that everything has been taken care well. Especially when you are doing the iris claw lenses, you have to make sure that you do the proper vitrectomy and also the peripheral iridectomy. So just to conclude, recognizing the problem post-operatively, even at day 1 or day 10 or 1 week, whenever you are calling the patient, and also at the end of 1 month, giving the glasses is the easiest thing. But recognizing the problem, even if the patient is having a 6/6, it doesn't mean that patient is doing very well. It is the qualitative 6/6, quantitative 6/6 what you are giving, but look for the qualitative 6/6 and everything else is being taken care. So thank you so much. Yes, sir. கேள்வி கேளுங்க சார்.
இல்லை சார், உங்கள் பாஸ்.
Can add your comments. Yes, you would have come across something.
Easiest of rise of intraocular pressure is steroid induced mostly. So you need not panic and stop immediately. You can wait. If the disc is normal, if the intraocular pressure rises beyond 30, then I might stop steroids, put them on some anti-glaucoma medication. Rest, as Sir said, inflammation, infection, retain lens fragments, you have to act either mostly surgically, as we have seen quite a few trabeculitis which need surgery, and invariably trab will fail, but IOP will be somehow controlled. So you have to be, you have to do a trap, so no other go.
That is called as a successful failed trap.
Successful failed trap.
Basically, whenever you have the higher IOPs, don't panic and give
Sir, for patients
Diamox,
with
multiple medications. Don't do that. Always start at one so that you understand whether that medication is working or not. Don't try to give 4 medications at a time, panicking that you bring down the IOP by tomorrow morning from 50 it is coming down to 4. Not really necessary. Because the disc is healthy, you need not worry. Sorry, please.
Sir, for patients with pre-existing glaucoma, like with optic neuropathy, who has got a hard cataract, which needs use of OVD. So we should go for OVD or like already cupping is there.
Yeah, see, basically, you are thinking whether the OVD in glaucoma patients are going to be high risk or not.
Yeah.
We need not worry about that. When you have a hard cataract, please use the OVDs properly so that your cornea is protected. The glaucoma patients, the corneas are also not good.
Not good.
So you have to use the OVD. The advice is make sure that you clear the OVD.
Clear.
Make sure that every part of the OVD is being cleared. Magnify it and see that below the lens, sides, everywhere, you just clear it off. Well,
Right.
whichever OVD you are using. All right?
Thank you, sir.
Come again, sorry. For? If they have a strong family history of glaucoma, you can possibly look at it, but not necessarily that everybody has to be a. But once you know that the patient is having a steroid responder, then of course you have to make sure that. But otherwise, you can't go on doing every patient a steroid response curve. It is not possible because we don't know whether the patient is going to develop in a day 2 the steroid response, or it is going to take 6 months to develop a steroid response. We can't do that. Because steroid responder is not, if it is exactly by day 3, if he has a spike, then things are different. Everybody you can challenge. But we don't know when they are going to have a steroid response. So it is not possible practically. Thank you.
Thank you, Satyan sir. That was such a wonderful talk. I request Chitra ma'am as a panel for the next topic, and Dr. Okay. Okay. Chitra ma'am. The next topic is on refractive surgery, the future of refractive surgery. Chitra ma'am, kindly join us as the panel, and Dr. Anant is our moderator for this session, please.
I'm sorry, I thought it's usually it will work, I think somewhere is a problem. Audio. There is nothing to be. Future, this is just a 5-minute talk. Future technology, future trends, what are there in refractive surgery happening around the, I mean, at the research level, what people are trying. And coming to that, there is something in the Israel guys are developing, nano drops. There's no, they just do some epithelial, audio varlama.
It's a revolutionary solution in the field of eye care. An accurate, safe, and ultra-fast laser-assisted device coupled with nanoparticle eye drops for refractive index modification. Here's how NanoDrop's 3-step process works. First, a calculation is performed, translating any prescription into a matching optical pattern. Next, the obtained optical pattern is created on the corneal epithelium through a speedy, painless, and high-precision superficial laser-assisted etching. Finally, biocompatible eye drops are instilled to locally modify the corneal refractive index by changing the pathway of the light rays. This sophisticated process ultimately modifies the optical power of the eye in the desired direction, without weakening the corneal structure or modifying its shape. In the huge and growing market,
So here what they are doing is they are not changing the shape of the cornea, only refractive index. Refractive index of the surface of the cornea will be changed, either negative or positive depending upon hyperopia or myopia. So there is no need to remove corneal stroma. So that's what they are, this phase 1 funding is completed, phase 2 funding they are doing. The other one is
TechLens has developed a non-invasive single treatment that uses light to gently strengthen and reshape your cornea, correcting nearsightedness, farsightedness, and the need for reading glasses as you get older, all without cutting or ablation. The doctor will first measure your eye and build a computer model of it to help calculate exactly how to apply the light for your correction. She will then put a few drops of vitamin B2 in your eye and apply a specialized contact lens connected to a tiny fiber optic that will deliver a precise pattern of light to your cornea for a few minutes. The light and the vitamin work together to strengthen your cornea, causing it to take a new shape for your prescription. As your cornea strengthens, it is better able to reflect sound, so the contact lens uses ultrasound to measure this effect, ensuring an accurate prescription. Learn more about...
Here they are not removing any tissue, just changing the curvature of the cornea by cross-linking. That's it's so interesting. Even J&J now they bought this company. They merged this company, J&J. They bought this company. This is a small company. Clinical trials already there. Right now they are doing only for ectasia. Now they are strengthening. The idea here is, as you know, in myopia, also we always think myopia is axial, but the small percentage, 10%, it's a curvature myopia. When you follow them, it will be 41, 45, 44 like that, 40, 45, 46 like that. The corneal curvature increases over a period of time. So these cases, they want to freeze the cornea before, in children you catch hold of them and freeze the cornea at 43 or 44. So the curvature myopia will be stopped. So axial myopia, as you know, we are using atropine and these drops or dim lens, all those work. But curvature, they don't work. So this is for curvature myopia, and they say they can do other things also. It's so interesting. J&J bought this company, and further they are evaluating. And coming to this, and we developed a small device. This is a PRK for slit lamp. So it's a slit lamp, not slit lamp, sitting position. It's a very small one. Small. You need a small room, just a small and it's not very sensitive to humidity. Also, you can just do your procedures in the outpatient. And even we tried. Even you don't need a spectrum. Patients are comfortable just looking at that. Just apply the ray. It takes around 1.5 minutes to 2 minutes for up to 6 diopters of myopia, trans-PRK. Then either you have to apply mitomycin or neo drops and put a contact lens. And the main thing what I observed in the immediate last few 4 or 5 years, it's a back to the future, and throughout the world they are changing to the lens-based surgery. In Japan, almost 50% LASIK surgeries have gone, so they are going for implants. The implant business is going up like anything, and cornea-based surgery is coming down in many countries, Japan, Korea, and China are not followed still, and Europe. These 3 places, lens-based IOL, PCA, phakic IOL is becoming more popular than LASIK. And another thing is we are expecting is every LASIK or every SMILE, I think once we finalize the protocols, I think they go for a cross-linking of some extent. That is assures you safety and more confidence for us to do the surgery instead of refusing many cases for one. Then the SMILE, as Anant might have told many times, you might have heard, the lenticule removal. Now what they are trying is on-surface lenticule. You don't make a lenticule inside the stroma, you just make one cut and peel it off like PRK and apply mitomycin. And only thing is you need a smooth bed, then the thickness issue will be resolved a lot. You need a one cut, the precision will be more accurate. If you take a one posterior cut and one anterior cut, dissection, nothing here, it will be much simpler procedure. Just on the surface, you make a lenticule and peel it off, apply mitomycin, put a contact lens, and that's the end of that's a very technically very simple surgery and less complications. And this what, they just remove the lenticule and apply it. Then coming to that, what we are expecting is we tried, it's working very well, but we couldn't progress in the diagnostics. In the for example, pentacam or anterior and what you are doing, you enter all your values and you select the procedure which is appropriate. The AI will be there. By the time you finish 1,000 cases or 800 cases, it will automatically learn. You don't give anything, it will learn. So once the patient sits there and you don't need to worry about anything. It will suggest according to you. It can be global. Global means it will be connected around the world. And what is the world trend? It will give around the world, this particular patient, SMILE is selected, or the best option, or LASIK is best option, or PRK is the best option. And it can be local. For example, Arvind has got a group, Eye Foundation has a group. In your group, what is the option in these cases, automatically it will give. We need not worry. Or it can be very personal. It can say that, Anant, you like this surgery in this patient. This particular patient, you like this surgery. We don't need to worry, take care of the records. So that gives more command for us to do, more confidence for us. So that's what the artificial intelligence, that's very simple. It's not very difficult. Already everything is there. Which one they have to select 2 or 3 random forestry, the 2 or 3 methods, which one they have to select. That's a very simple thing actually. Why it's not implemented, I'm not able to understand. This is what I'm telling. It can be global, it can be local, it can be personal, all 3 it will give. So automatically the patient goes, you need not worry, you don't need to screen also patient. The problem is the future is unpredictable. So whatever people expect all will never happen most of the times. And here history is merely a list of surprises. It can only prepare us to be surprised yet again. So all this may not happen, and some other thing may pop up in the future. Be prepared for it. Thank you.
It was nice to hear Dr. J.K. Reddy. His brain somehow works totally different from the normal routine. So he took us to a dream of how all things can be handled. It made us realize that, yes, such things could be done. Some way to change the refractive index or the curvature and all. But I believe that, to my mind, I believe that the present procedures are pretty standard. There would come some a tool to understand the corneal biomechanics of the tissue better, and that would help us refine our decisions.
See, this is
whether
the problem.
to do cornea based or
See,
lens
last
based.
time I went to NN biomechanics of cornea, they are arguing. Ultimately, you are totally confused. So
We haven't
NN
got the
says,
right
no,
tool.
no, this is completely wrong. We are defining everything. The machine is developed in a wrong way, and there is completely wrong. You have to merge this 0.43, 0.53. And Anand says, these are all nothing. You just see topography, do it. I have done 10,000 case, 20, nothing will happen. All this is to make the instruments they are promoting. There is nothing necessary. And another says PRK. Now, once we have AI in the place, so we have a global trend and a global consensus, and you are very strong in the court of law or in the, at least for you. If you are not, there are 2 types of practice. One is defensive medicine, one is defensive medicine is every time you think if the cataracts comes, endophthalmitis, what is my liability? So the other thing is let it come, we'll face. How many doctors went to the jail due to endophthalmitis? Maybe 1 or 2 in entire 100 years. So thinking about that one person, every day you will be suffering in the OP. So there is no need for that. So defensive practice. So once AI comes, you got evidence. You got in the court evidence. This is the global trend. I am following it. Your minimum standard is there, expected standard. So these arguments like biomechanics and all those things, topography, this machine is better, pentacam, posterior float, all this will disappear from us. Whether the patient is fit or unfit, what most of the doctors are doing.
Thank you, JKR sir, for taking us through the innovations of future of refractive surgery. I next request Dr. Siddharthan to join us as the panelist and Dr. Shiv Prasad as the moderator. Dr. Shrish Kumar will be talking to us on the tips and tricks of dealing with the
We'll invite Dr.
pterygium
Shrish for
surgery.
pterygium.
Dr. Shrish, please.
Good evening. At the outset, I would like to thank Team Lotus and Dr. Anant for giving me this opportunity. And Anant was very apologetic when he contacted me when he was fixing the program for this meeting. So, will you talk on pterygium? He was very apologetic. I thought it is a very simple topic, and I'll not be interested in talking this topic. But I know this pterygium is one of the commonest problem we encounter in our day-to-day practice, and definitely my talk is going to be useful for the PGs and for the fellows. So I'm going to talk on tips and tricks for successful pterygium surgery. We've been doing pterygium surgery for the last many years, 20 years now, and there are various surgical procedures that are available, but there is no standard protocol for the management of pterygium. So we have to choose an ideal procedure for the particular case. And that is, if it is a single head pterygium, what type of procedure suits, a double head pterygium, recurrent pterygium, and if you are combining it with the phaco. So the chief goal of pterygium surgery is it should prevent recurrence. That's why we are doing this. And it should act like a limbal barrier, and it should prevent conjunctivalization of cornea, and there should be minimal or no complications as such, and it should be cosmetically acceptable to the patient and the surgeon. And we, based on our experience over the years, we prepared one algorithm and we published it in recently it got published last month in Romanian Journal of Ophthalmology. So the treatment algorithm for the management of pterygium, and this is what we prepared. And for primary pterygium, divided them into single head and double head, and what are the procedures that are available and that are suitable. And for recurrent pterygium, again for primary and single head and double head, what are the surgical procedures that works very well. And there are occasions, we all know conjunctival autografting is the gold standard in the management of pterygium. However, there are occasions where the superior bulbar conjunctiva is not available, or it is has to be preserved in conditions like patients with the bleb conjunctiva, glaucoma filtering bleb, or glaucoma suspects, wherein you need a conjunctiva for future filtering surgery. In such cases, we can try this conjunctival tissue grafting from the pterygium itself, that is CTGP. And what we do is we take a tissue from the pterygium tissue itself, and we keep it aside on the cornea, and then remove the fibrovascular tissue of pterygium and place this tissue on the base scleral bed. Either suture it or you glue it. And we subjected this tissue from the pterygium for histopathological evaluation. It is no different from the regular conjunctiva, but it is more brittle, less elastic, and it's thicker as compared to the normal conjunctiva. And it has 8 to 12 layers of epithelium, and even goblet cells are seen. There is no atypia, no dysplasia, or no malignancy noted in these tissues. It acts like a barrier. It can be used as a substrate for base sclera to cover the base sclera, and this is how the procedure is done. It's a PPTX. It is incorporated. It won't. Okay. So yeah, I'm not able to show this video. It's incorporated actually. File irukku, but minimize பண்ணி
எங்க இருக்கு சார் ஃபைல் அட்டாச் பண்ணிருக்கா
அட்டாச் பண்ணிருக்கேன்
எங்க சார் அந்த ஃபைல் சார் அது வேணா ப்ளே பண்ணிட்டு அப்படியே ஸ்லைடுக்கு போயிடலாம் சார்
So this is the procedure. We inject saline or lignocaine into the substance of pterygium to raise a bleb and separate the conjunctival epithelium, the pterygium epithelium, which is thick. Actually, it is brittle and it is thick as compared to regular conjunctiva. And then you remove the fibrovascular tissue and place this graft on this bare scleral bed. This is how this is done. And we published this concomitant use of conjunctival tissue graft from the pterygium, and it was published in 2019 in IJO. And the results are comparable to conjunctival autografting, and the recurrence rate was less than 5%. Again, we compared it with inferior bulbar conjunctival autograft because inferior bulbar conjunctival autograft is also done for similar indications, and the results were comparable. And both the techniques of inferior conjunctival autografting and conjunctival tissue graft from pterygium itself are excellent alternate options with comparable outcomes, and no additional risk of significant complications were noted. Coming to double head pterygium, and this is again one of the difficult management problem because you have a large bare area to cover, and these are the options that are available. And we again prepared one algorithm, and that was published in DOS TJOSR and published last month. This is the algorithm, and these are the surgical procedures that are available for us for the management of double head pterygium. And vertically split conjunctival autograft, we can split the conjunctival graft either vertically or horizontally, and vertically split conjunctival autograft without limbal orientation. See, if you split the conjunctival autograft and you place it on the bare scleral bed, this is the area which is not covered with the conjunctiva, and this is a potential source for conjunctivalization. So in such cases, what we can do is you split the graft and slide the graft down without changing the orientation of the graft, and then place it on the bare sclera that covers the entire bare scleral area. And this is a split conjunctival autografting. Of course, like it's not working here. We published this particular procedure in IJO, and later on a large series was published in Oman Journal. It was published in 2020. And we compared this vertically split conjunctival autograft with and without limbal orientation in cases of double head pterygium. There is no statistically significant difference as far as the recurrence rate was concerned between these procedures. And horizontally split conjunctival autografting, again this can be tried in double head pterygium cases. So you just split the graft horizontally and place it on the bare scleral bed. And we compared horizontally split conjunctival autografting with vertically split conjunctival autografting, and the recurrence rate was below 5% in both the cases. And this is for recurrent pterygium. Recurrent pterygium, I do what is called extended resection, and I do extended resection of the pterygium, excise the tenons half a centimeter beyond the cut conjunctival margin, and then take a conjunctival graft and include a peripheral corneal tissue, a thin block of tissue around 0.5 millimeters onto the peripheral cornea, and include it in the conjunctival graft. This works very well. And we published this particular procedure in almost 90 cases in International Journal of Ophthalmology and Visual Sciences. And recently we published this in DOS Times, where we compared extended resection with the limbal conjunctival autograft versus conventional conjunctival autograft. And the recurrence rate, this is for recurrent pterygium, the recurrent rate was around 3% for limbal conjunctival autograft, and it was around 4.5% for regular conjunctival autografting. So choosing the procedure for a particular type of pterygium is very important. We can reduce the incidence of recurrence by choosing a proper surgical technique. The second important aspect is choosing an ideal graft fixation method. You have three best options: suturing, tissue adhesive glue, and autologous serum. Again, we compared all these three different fixation procedures and published in Oman Journal. And glue and sutures, the recurrence rate was comparable, and it was less than 4% in these two procedures. But the recurrence rate with autologous serum was slightly more in our series. The reason was because of graft loss in a few cases. It was more than 5% and 7% to be precise in our series. And what are the other causes for recurrences after conjunctival autografting? If you include a graft which is small, like if you see here, this area is bare sclera, and it is not, this graft is not covering the area. Insufficient graft size is one of the common cause for conjunctivalization and recurrence of pterygium. And if you are taking a thick graft with the tenons in the graft, that again causes retraction. Of course, cosmetically it is not acceptable to many of the patient, and it causes irregular bump on the surface of the eye, and you should not include tenons in the graft. And graft retraction is another cause for recurrence. If your graft is small and if it is retracting, if it is attached at the limbal end, the chances of recurrence is less, but if it is retracted from the limbal end, there is a chance of recurrence. You have to slightly oversize the graft and fix it properly to the vascular bed. And next common cause is graft inversion. If you place the graft upside down, it can lead to rapid sloughing of the graft, like what you see here, and this will incite significant inflammation in and around the wear area, and that causes conjunctivalization, and this needs to be removed. This slough, you can't leave it like this. This slough has to be removed. And inadequate peripheral excision. If you see, there is a knuckle of tissue which is extending from the periphery. Here there is a graft, and that is acting like a barrier, but here there is no graft. It is there is a knuckle of tissue which is extending onto the cornea. And persistent inflammation is another cause for recurrence. Graft loss again, if your fixation is not properly done, we can lose the graft, and a bare sclera is one of the cause for conjunctivalization. And the last important aspect is inadequate stabilization of the graft. So to improve the outcome for a successful conjunctival autografting, what you have to do is you have to obtain a large and a generous graft, and it should be a thin graft, without the inclusion of tenons in the graft. And next is, like, this is actually, I want to show this, this is actually a case wherein I have done a temporal pterygium surgery long back, and now the patient has developed nasal pterygium, and I'm using the same bare area for as a second donor. So temporal pterygium has been excised, and there is a graft here, and now the patient has a large grade 3 pterygium here on the nasal side. And you take a graft. If the graft, the initial graft, you have not included the tenons, you can take the same graft. And even this can be used even for filtering surgery also. It looks slightly like opaque, and it is a thick graft, but it serves the purpose. And then adequate stabilization of the graft is very important. And efficacy of second donor conjunctival graft, we published this. We took graft in 23 cases, and only one patient had a recurrence, and this was published in IJO. And the other factors are like fixing the graft, adequate stabilization. Here you can do what is called tuck-in grafting. You can tuck the graft under the cut conjunctival margin, or you can even cauterize the edge of the graft, and so even if you are using autologous serum for fixation, that will stay. And overnight patching is mandatory in these cases. This actually is published in Women Journal recently. Tuck-in versus graft edge cauterization. So to conclude, we have to choose a right surgical procedure for a particular type of pterygium, and the right method of graft fixation has to be done. This will give optimal outcome in these cases. Thank you very much. Thank you.
Thank you, Srish sir, for your sharing your wonderful depth of knowledge on pterygium. I'm sure all of us have found it very useful. And sir, do you would like?
Sir, that one, have you heard of Terigo, the contact lenses? You have not heard of it. So that just for a completion's sake, I think just like JK sir was talking about newer things, this new contact lens has been come. I think in North India they've been doing 21 mm diameter, 75% hydrogel contact lens, no glue. Then more than 500 cases, and they're telling Kakadia, I think Dr. Kakadia has done. It's known as Terigo, Pterygium Go. So I think that's one new addition which has come. I think we should try it and see. But as sir was telling, pterygium with glue is the standard now. So I think newer technologies, newer techniques might come, but the proven ones always remain the best. Thank you.
Thank you, sir. May I request Chitra ma'am now? She'll be talking on cataract surgery in keratoconus. I request Dr. Anand to join as moderator and JKR sir as panelists.
Very good evening to one and all of you, and I'm truly happy to be invited by this lovely Lotus family team. And my homages to this very unique, dynamic person, Dr. Sundari Murthy was, who we've observed over the last 2 or more decades, competing and growing side by side along with us. And if it was possible for him to see from wherever he is how wonderfully this team is carrying forth his dreams, I think it would be something of worth reminiscing. So let me try to keep my talk as crisp as, am I audible? Okay. So my due is to talk on cataract surgery in keratoconus. Now why cataract surgery in keratoconus is a challenge is there are certain pre-op considerations which have to be taken into account for us to get as near optimal outcomes as is feasible. Now we also know that it's a steep cornea, thinned out cornea, but there is a significant astigmatism in it. So my due is going to be talking on when would I use toric IOLs and what are the other angles of support which I'm going to use. So when you are considering to correct the astigmatism with toric IOLs, it is absolutely a clear mandate that we should only deal with mild and moderate keratoconus. It has to be a non-progressive disease, or the disease is in its quiescent stage and not in a younger age group. And these patients should not be used to wearing a rigid contact lens, because if they are keen on wearing a rigid contact lens, you know they have irregular astigmatism, and toric IOLs is not an answer for these cases. They should have had some fair amount of BCVA, at least better than 20/40. And it is important that the astigmatism needs to be regular in that central 4 millimeter of the cornea. We have to remember that this patient may not be, it's a mild keratoconus, he may not be going in for a corneal transplant in his life, because if you do a corneal transplant and you have implanted a toric IOL, then the corneal astigmatism is no longer being neutralized by the toric IOL, and the toric IOL power would get manifest. The other important thing, if it is a post-PKP, again it should be a regular astigmatism. So when would you not use a toric IOL in a cataract surgery? If the patient has advanced keratoconus, a progressive keratoconus, or has an apical scar, or if a graft is being considered. Again, these patients would do better if they have a centered cone as against a decentered cone. And if he is a previous contact lens wearer, then we need to ask him to remove his lenses at least for 3 weeks to a month. Check whether the repeatability of the Ks are there, because that itself would be a huge challenge in the IOL power calculation. And in fact, if it's a mild keratoconus, you could even do a topo-guided regularization of the topography, a little early moderate, you could even do an intax, allow the eye to stabilize, then go ahead and take your K value measurements. And if you have doing the topography, which is one of the most essential measures, we have to look for a regularity of the topography in the central 3 millimeters. If he is a patient who's wearing an RGP lens early on, do not fit a toric IOL. You should go for a monofocal IOL in this patient. Let him go back to wearing contact lenses after the cataract surgery. So what are the challenges? Repeatability of the K. So then we need to repeat our measurements till we get similar K values, treat the ocular surface, the tear film irregularities. The most important challenge in a keratoconus is the ratio of curvature, of the anterior curvature to the posterior curvature is altered. It's not that the changes are manifest only in interior, significantly in the posterior. So when this ratio is altered, the usual refractive index of 1.3375, it does not hold good. So you cannot be using any of your earlier formulas. Again, the K value, which is normally used to predict the effective lens position, is not going to be relevant because it's a steep K. So it would, a keratoconic eye, it will presume that the effective lens position is more posterior than what it is. So there's a false evaluation. And again, the anterior chamber is deep in the center than in the periphery. All of it ensures that the ELP estimation is not very accurate. So what happens when you're overestimating the K, you tend to have an hyperopic surprise, and that has to be factored in. And the hyperopic surprise is less in a mild keratoconus, more in a moderate, and very significant in a keratoconus over 53 diopters. So as I said, the ocular surface is not going to be regular, so there's going to be dry eye issues, there could be increase in inflammatory markers, and all these have to be treated before your biometry values can be incorporated. And if there is a continuously standard deviation in your K values are irregular, you keep repeating your measurements, and maybe you might have to use the lowest K value, because it is better to leave the patient a little myopic than leaving him hyperopic, and because he's used to a little myopia earlier on and he's happier with that kind of vision. If he's a hard contact lens or a scleral contact lens wearer, you need to discontinue. The measurements have to match, and as I said again and again, aim for a myopic target. Now, the posterior corneal astigmatism, interestingly, in a keratoconus is more often with the rule than against the rule. In normal eyes, 90% of the cases are against rule, but here in these astigmatic corneas is more often with the rule. And the modern IOL master 700 with the TK values and the EKR values are maybe the better ways to go than the earlier measurements. As far as the IOL formula which is to be calculated, earlier people were happy in SRKT, SRK2. SRKT seemed to function a little well because it tends to give a myopic outcome, and getting a hyperopia is the biggest challenge, unhappy challenge in a keratoconic eye. Now we have better formulas like the Keynes formula, but again in the Keynes formula you should use the anterior corneal values and not the posterior corneal values, and leave the formula to predict the posterior corneal values. And if it is a very early keratoconus, no adjustment is needed for the final predicted refraction. But if it is a mild keratoconus, 0.75 to 1.5. If more severe keratoconus, you need to aim for a myopia of -2 to -3. So this is again a graphical representation which tells that the Canes or the Barretts seem to do better. And next comes SRKT as against the other formulas, which are the third generation formulas. So again, this is another thing wherein a Barrett's TrueK formula is being used for keratoconus and has gained significant popularity and can be available on the APSCRS website if it's not there on your optical biometer. And you need to feed in the anterior corneal values and allow the formula to predict the total corneal values. So what is the timing of the surgery? If the cornea is fairly irregular, you decide whether there's astigmatism, go ahead and do a toric IOL, or if the patient wants RGP, keep him on a monofocal. And if the cornea is not regular and it is still a mild to moderate, you could do a topo-guided regularization or an Intacs and then do it. Now these are cases where the patient had a decentered cone and the cornea has become more symmetric, and then you are able to do a toric IOL implant. Again, this patient had a decentered cone and Intact surgery was done, the topography was regularized, and then this person has a better centered cone and would do better with a toric IOL. Again, the toric IOL is not going to be exact, but you have to explain to the patient there's going to be a debulking of the astigmatism which occurs in these eyes. Now, this was the surgery for keratoconic eye, wherein the Intacs was already there. And so the rhexis, because of the overlying Intacs, you're not very clear whether there may be some area tissue bridges which have not opened up. So you need to use your system, you need to use to ensure that the rhexis comes through, because again the rhexis tends to retract behind the Intacs, so you may be not able to visualize the rhexis margin at all times, but these are invariably soft cataracts. Again, when you're teasing out the cortex, you need to be conscious. Now sometimes the cornea would be fairly irregular. You could even just place enough viscoelastic on the cornea to give a depth magnification and some further steep cones. You could even place a contact lens on the cornea, the kind of lens which the patient is used to wear, and that gives you visibility to do your cataract surgery. If it is a PMD, you can do fairly well because the central cornea is more symmetric. So these patients, you could still do a toric IOL implant, but you have to use a customized toric IOL because the amount of astigmatism is significant. When it is a post-PK or a DAL, you have to wait for the cornea to stabilize, remove the sutures, get the repeatability of the K values, and use a customized toric. I'm just going to show you very rapidly how in a PK, like in a graft, you could either do a scleral tunnel, or if the graft is smaller, you could make a near limbal incision can be made. You need to protect the endothelium at all times, and you can do a low parameter phacoemulsification. Often these eyes could be highly myopic, so you have all the challenges of a myopia, like you need to keep your parameters low, you could have a reverse pupillary block, you have to increase the IOP RAM slowly so that there's not a sudden pulsation and sudden widening of the pupil size. And also there's a lot of vitreous syneresis in these eyes, so you need to be conscious that your parameters are kept low. Again, in post-DALC, it would be a similar issue. We need to make our patient cognizant of the fact that there could be a refractive surprise. You might have to do an IOL exchange, or you could place a piggyback IOL in these eyes. Anyways, the anterior chamber is quite deep in these eyes. So I would like to summarize stating that we have to take in account not just the anterior corneal part, but the posterior corneal part, use a formula, a Keynes formula or Barrett's formula, or maybe in the last resort an SRKT, and look at the corneal map on the topography, and if the cornea is fairly symmetric in the 3 to 4 millimeter zone, you could incorporate a toric IOL. So I would like to conclude stating that in the right circumstances, cataract surgery with the toric IOL would definitely improve the BCVA in these keratoconic eyes. Thank you.
Very nice presentation. She covered everything, but too much for to remember, especially for the newcomers. For example, Satyan, if he comes keratoconus, I don't think he will remember. He will forget everything. He will again search. Too many points. Another thing is, what we found is keratoconus. Most of the people, at the time they come with the spectacles, they are wearing some spectacles, before. You check the axis of that cylinder. If that matches with the axis of hair reading, then it's fine. You are going to do reasonably well with toric IOL. If that doesn't match, for example, you are 160 degrees, sometimes there will be a flip, many cases. The keratometry will be in 180, but the patient will be accepting some 60, 70, something like that. Some bizarre, we cannot, we don't know what is that optical phenomena. So those cases, better to avoid, put a spherical equivalent, give cylinder spectacles.
There's one interesting thing. We had a class 2 days back. I wanted to add that in the talk. A patient has a very severe keratoconus. Apparently, the Barrett's formula does not give IOL parts beyond 50 or 60, nor does the Keynes. So in those situations, SRKT seems to come into vogue. So that is the only area now SRKT has a small role, is in the severe keratoconus eyes. So that was information for me. Thank you.
Thank you, ma'am, for such a wonderful talk and putting all your wonderful experience of so many years in such a crisp talk. I request Dr. Ashish now to give the vote of thanks, please.
Good evening, everyone, and thank you so much, Miss. I do not have my words to express our gratitude from the entire Lotus team, me seeing each and every one from different institutes. I think that's such a mark of respect towards our chairman, when I see, all the institution heads are here. Means taking time out from your busy schedule. I know, how accomplished clinicians are present here. I think this is a true mark of respect for our chairman. And it is almost, past dinner time, but still, so thank you so much. And I think this is the cohesiveness and the love of this society, Coimbatore Ophthalmic Society. And probably that is something which has inspired us as a Lotus team to keep working hard even when our chairman is not with us. So with the help of all the wonderful colleagues like you, with your strength, I think we would like to grow further. So with this, a tiny mark of respect, I would like to invite Dr. Anand to just felicitate our speakers of the today. So first I would like to invite Dr. Ganesh Raman, sir. Dr. J.K. Reddy, sir. Dr. Satyan P, sir. Dr. Shirish Kumar, sir. Chitra, ma'am. Prabhu, sir. Prabhu Shankar, sir. I think he left. No problem. Satyan, sir. Satyanan. Siddharthan, sir. Our in-house Dr. Rita Singh. Dr. Rajkumar Chaurasia. He left. Dr. Usha. Shiv Prasad. Shiv is here. And I think on behalf of all our Lotus team, we would like to felicitate Anant, who was the core organizer and the brain behind this meeting. Yes. You know why Ganesh sir came first? Because Ganesh sir was the first one to present here today. So thank you for that, sir. Thank you once again, each and everyone. And cocktail is here, and if you can join us for the dinner in Topaz.